Welcome to the Adult Obesity Guidelines webinar series hosted by the Office of Long Learning at the University of Alberta and Obesity Canada. My name is Denise Campbell-Scher. I'm the Associate Dean for the Office of Lifelong Learning, as well as a family physician here at the University of Alberta. It was my great pleasure to serve on the executive of the Canadian Clinical Practice Guidelines. The new Clinical Practice Guidelines are expansive, 19 chapters on a wide range of topics related to obesity, diagnosis and management, weight bias, and more, all written by Canada's top researchers, health practitioners, and patient advisors. They're the first truly patient-centered clinical practice guidelines on obesity and the result of more than 3 years of hard work. We are delighted today to be presenting on multimorbidity and patient complexity, opportunities for obesity management with Indigenous people. Just before we begin, I'd like to go over a few items. We acknowledge that we are on the traditional territories across Canada of the many First Nations, Métis, and Inuit, whose footsteps have marked these lands for centuries. If you have a question pertaining to technical difficulties, L3 and Obesity Canada programs and services, please use the chat feature of the webinar located in the middle of the black bar on the bottom of your screen. If you have a question for our panelists, please use the Q&A feature of the webinar on the right side of the bar on the bottom of your screen. Our panelists will answer several questions following the oral presentation. Some questions may be responded to through text in the Q&A window. You can at any point use the Q&A button at the bottom of your screen to submit questions. We anticipate many questions, so please review what's already been asked and upvote those questions you'd like to have answered. We cannot guarantee that panelists will be able to respond to all of your questions. A recording of the webinar will be available next week. It was sent via email to all of those who registered. Additionally, we're working to settle the timing for the bariatric surgery webinar, and we will email you as soon as that information becomes available. Please note that the link for the webinar is for your personal use and is not to be forwarded or shared. This activity has not been formally reviewed by the CFPC or Royal College. However, it is eligible for non-certified credit. Main Pro Plus participants may also earn additional certified credit by completing a linking to learning exercise. Please contribute your experience with obesity management to inform our advocacy and programming. While you're waiting or after the event, please take 5 minutes to contribute your perspective. We are very pleased today to have Dr. Lindsay Crowshoe, Associate Professor at the Department of Family Medicine at Cumming School of Medicine at the University of Calgary, join us. Lindsay is Piikani First Nation's family physician scholar with experience leading large multidisciplinary provincial, national, and international research teams focusing on chronic disease and social equity within areas of primary healthcare, public health, and health education. He has secured numerous CIHR grants as the NPI, results in PHC research outputs that have informed policy, system, and practice within Canada. Within his research, teaching, and clinical activities, he focuses on bringing multiple disciplines of knowledge, including health, clinical, social sciences, and Indigenous ways of knowing, ensuring each is centered within traditional ethical principles and protocols. He provides clinical service to the urban Indigenous population of Calgary at the Elbow River Healing Lodge, an AHS primary health service model. He has provincial leadership experience in Indigenous PHC services, systems, and policy, provides national input on Indigenous PHC, and has led multidisciplinary Indigenous PHC teams, both on reserve and urban. He developed innovative Indigenous PHC services within AHS for urban Indigenous populations and on reserve within Treaty 7. He provides direction for the provincial and national professional health organizations, and his input has resulted in numerous policy directives for medical schools across Canada related to Indigenous health admissions and education. He has led development and implementation of Indigenous health programming within the medical school, beginning with equity-based approaches to recruitment, admissions, and support of Indigenous medical learners. He has worked to ground institutional direction within a deep engagement with the Truth and Reconciliation Commission of Canada Health Legacy Calls to Action. He has actively monitored hundreds of Indigenous and non-Indigenous medical and research learners in his career, as well as having taught directly thousands of medical learners within the classroom in his clinic, focusing on building critical knowledge of Indigenous health. So with that, I'm going to turn it over to Lindsay for the formal portion of the session.
Okay, excellent. Okay, thank you for the introduction. Really appreciate the chance to share this work. The that bio that when people ask me and I send out, I have to like adjust it to make it easier for people to read off. So next time it'll say he's a guy or a person who does stuff, and he likes to do lots of stuff, and leave it at that. So anyway, so we'll launch into this. So I'd like to acknowledge my uh, my um, my colleagues to help to build this chapter. All of the hard work that each of the co-authors put to this, all of the people that we engaged with over the process of making sense of this, which included a whole host of health service professionals as well as Indigenous people who willingly came to the table to help make sense of the literature and to provide direction and to the fuller organization that helped us support an Indigenous chapter. So a big shout out and thanks. I'd like to I guess I'd like to jump in now. Dr. Henderson, who's the lead author, asked me to give the presentation today, and as it connects deeply to a lot of the work that we've been doing and some of the work that sort of connects, deeply connected to the diabetes work that we work with together on. Okay, so we'll cover the context of this chapter. We'll have a chat about the methodology, and I'll share some of the key recommendations and messages, and we'll have a chance to chat about what it might mean, and have a larger group of the authors to provide their context and provide their perspective. So that's kind of the plan. All right. Okay, so the idea of understanding obesity, like for any population, there's a host of complexities that we need to hold with it. Understand what these complexities are. We have to look and understand that Indigenous people have experienced a history of colonization, and that operates at a very interesting and convoluted social interaction of Indigenous people with Western society, and that individuals that have experienced this through multiple generations within their world have created a host of the life around them is very specific, that kind of is deeply connected to these ideas and these these outcomes. Sorry, I'm just rambling here, but the main point here is that that in the way that colonization operates to create outcomes, Indigenous peoples have been experiencing that and experienced that from an intergenerational perspective. And that for us to understand obesity, we have to tap into what are those experiences historically, and what are those current experiences that an individual holds. The idea here is that the disconnection and the dislocation and the disruption of life creates a whole host of barriers that an individual person experiences. There's a central concept of stress that started to come to the table, that was clear that as one experienced that life in a host of hardships that came about from these structural issues that included ideas of pervasive poverty, not just of the individual, but within family and within the community, and lack of access to resources, and not just resources, but poverty at a systemic level that infiltrated into education and housing. Those are all super stressful. There's another domain which operates in a kind of like the inter-social domain that is perpetuated as a result of colonization, which is not just between sort of individuals within our community, but amongst broader society. That was super stressful. That in sort of the central aspect to this was that stress is like felt as a huge burden, and it made it hard for people to cope, and that influenced health behaviors and abilities to shift. So hand in hand, those things are very overwhelming. There's another level which I'll allude to, but we'll share more over the course of this presentation, is the effects of ongoing policies of colonization within structures of society, including our healthcare system. So those are kind of a bit of an overview of this, some of the big complexity. And so this point here just speaks to that these aren't in isolation. They sort of build on each other, and they happen they happen in a synergistic way, which is the reality of day-to-day life. And so we had a chance to like make sense of this, and we'll share more of what that means to everybody today. This slide here is just to give us a picture of the interconnection of how these structural inequities that we are arguing are the central experiences of Indigenous people, many peoples throughout the world as well, but understanding that structural inequities, so those things that are social injustices that create poor outcomes at a structure of society level, such as the healthcare system, the political systems, the legal systems, the economic systems that Indigenous people have been excluded from, have created poor health outcomes, and poor health outcomes in terms of big, huge gaps, disparities, and inequities as a result. So a lot of the work that we need to do needs to think and understand those upstream causes, because it makes a difference to how we think about accessing that world of the patient and then supporting that patient, whether it's at an individual level or thinking beyond the individual to how do we support broadly at a system level or community level to help address and create better outcomes. So that's some of the thinking behind this chapter. Okay. We ground ourselves in Indigenous research methods, centering the concepts around a host of ethics that we see spelt out, clearly defined, that we work within to make the work that we do good with Indigenous people. As always, we felt that there was a paucity of research that was clearly providing direction to us, and so we had to think through how it is that we should best approach this evidence when we saw that much of the evidence, which was the very rigorous and sort of systematic review process, was telling us something very similar, that we need more research. So we elected to add a few extra steps to the research process, to this process, to help us to understand what is the evidence truly saying. So in which case we underwent a realist review process in which we defined a host of questions that we, from working with Indigenous community, who was our realist review group, to make some sense of how do we understand this literature, what does it mean, what are the directions that we can sort of pull from it, by having this very rigorous grounded check-in process that was not just like an hour, it was a multi-session interaction with a host of individuals, which created very interesting synergies and relationships and ideas, and it allowed us to go very deeply as to understanding what does this mean for us from looking at the literature, and what does it mean beyond. So okay, so individuals, we did this work in Calgary, but the individuals in an urban setting, yeah, I think Indigenous peoples in an urban setting usually, often, most likely represent diversity across our nation. In my work and working with Indigenous people in an urban setting, we often have to be very cognitive of that diversity and respect diversity on the table, and also respect that Indigenous urban people have a unique experience of structural inequity because of being urban. And so these guidelines reflect kind of that diversity, that sharing, that centrality of respect for each other, which we argue that it is very applicable to Indigenous people across Canada. Much of my work is focused on reserve populations and First Nations populations, which is great and great deep grounding. I think we argue that this methodology of working with diversity creates an interesting and important pluralistic balance amongst a whole host of factors that then is contained within the research work. Um, we needed to ground our knowledge based on a framework because we're seeing some big alliances with the work that we also do within Educating for Equity. And this is a slide just to show some of the principles from that work, which is about diabetes, and it helped to facilitate some knowledge products that are connected to the Canadian Diabetes Association clinical practice guidelines. The project is called Educating for Equity. It's still undergoing. We sort of framed this from our national work with Indigenous people and service providers quite a few years ago now that we are moving forward on. We utilized that structure, which is a host of principles and a host of concepts to allow us to understand what we were seeing within this within the evidence that we're building for this obesity chapter. Central to the work that comes from Educating for Equity that I like to share because it helps me to describe some of the complexity. So our initial slide was, oh, it's really complex. Um, this helps to keep a lid on that complexity, knowing that if we have a good structure to work from, we can make sense of that complexity. This is a concept of how inequity through various pathways links to chronic disease. So we employed this construct to help us to make sense of what we were seeing in this evidence. So, all right, so I'll speak through the three pathways and share some of the basic information as we go along. I'd like to highlight components and then leave space for conversation. So materialist pathway. So I gave you a heads up already around these pathways in the first few slides as I spoke. This allows us to go a little bit deeper. So the materialist pathway, and just again, think about what the literature says and think about our urban-based realist review group that helped us to make sense of this. There's a huge sense of loss, a history of loss, a history of starvation that if you look into the literature, there is policies implemented against Indigenous people, policies of starvation that go hand in hand with this process. These are living memories that each of the individuals and that the literature we're speaking about that has impacted the ability to be well and impacted obesity, right? So so one has to tap into this. So I'll just make this a bit short, right? So community level poverty is prevalent, and Indigenous people experience a lack of employment opportunity. So hand in hand, it makes this pathway very powerful. Food insecurity, household income is low. People are struggling, and they report that interface between the whole host of stressors plus poverty makes this very difficult. So the idea here is what do we do to support better outcomes? I know one of the chiefs of my reserve speaks to health is a political thing and it's poverty is the centrality to it, and therefore one needs to focus on that. And he's speaking about the structural issues, right? Structural competence. He's a traditional ceremonial leader, and he facilitates ceremonial conversations. And the other day, my conversation with him around suicide prevention, he says he brought some young people together, and he was speaking about concepts of mental health continuity and role and responsibility and citizenship. And then he put them through a ceremony, and he says 10 years down the road, these people are still thriving, but there are young kids that were thinking about suicide. The idea of here is chicken or the egg. How do we balance this? Do we do cultural competency or addressing supporting cultural issues first in terms of sovereignty and continuity and safety, or do we address the structural issues? And the answer, from at least from what I'm hearing from my long relationship with the chief of my reserve, it's both, and we have to be very sophisticated in the way that we employ these. So that's kind of what the message that I pass on to everybody here. We have to be excellent enough to understand the difference and have tools in our pocket to have that ongoing conversation with people. So there's a quote here that if I'll just give you a moment to read, and I'll pause for a second. Okay, a nice healthy pause. Okay, so this speaks to some highlights of the second pathway, the psychosocial pathway. So psychosocial as defined as that space from social relationships and the psychological impacts. And the concept is big and broad. And if you look at the literature, it's like it's all over the place as to what do we truly mean about psychosocial in the context of clinical work. I think we have a bit of a handle on it there, but in the context of research, population health research, health services research, social sciences, there's a bit of a kind of a moving target, which means that it's a pretty important concept for us to nail down and make sense of. And that's what we try to do within Indigenous health research. So our header is psychosocial pathways to health inequity, addressing resistance, seeming apathy, and paralysis. So the central concept of our idea here was that there was a whole host of stress, once again, that creates a connection to certain behaviors in one's life, but also behaviors in that doctor or nurse or health service provider and patient interaction. We start to like make some sense of the importance of this resistance. The importance of this resistance in terms of if people are like actively sort of struggling to figuring out and they show that struggle, that's a positive thing. It's a super positive thing that that saying I don't really agree with what you say and I'm going to like do something else is part of that journey of making sense as we have ownership. So we felt that resistance in that we were seeing in the literature and within the realist review group was a super positive thing that you can say, okay, let's figure it out. It creates an opportunity for concordance, negotiation, and a chance for you to be humble and say, okay, let's make it work for you. On the other side of the coin, the idea here that sometimes it seems like part of the outcomes of all of this is apathy, right? So we saw that as not knowing what to do and feeling paralyzed, and the onus is on us for us as health service providers is to make sense of that. How do you somebody's coming to you and they're obviously wanting to some support, but they feel like they're stuck and they can't move. How do you start mobilizing that? That's another opportunity unto itself in terms of understanding, well, what are those things that paralyze you? We also recognize within this moment that some of that apathy could be a projection of us, right? Of our own sort of like feeling like, oh, I don't know what we could do, and I feel I can't do anything. So that creates an interesting dynamic. So those are some of the things that we're seeing as this part of the of the chapter. Yeah. So the as you can see, the quotes talk about being stuck, survival mode, right? Always having to worry about, just getting your basic needs. A lot of the conversation that we had talked about, and we thought through was Maslow's hierarchy of needs and how just getting the basics were hard enough, but how do you like self-actualize with all of those sort of things that get in the way? And so if we could understand that sort of a whole host of constructs within this conversation, maybe we can help people to move through those things. So, we'll highlight. I'm just highlighting things as we go through this to show that there are some recommendations and how they're connected to this, right? A lot of the conversation was interesting sort of observations of differences and like why is it like that for non-Indigenous people but not for us. So there's a lot of struggle and self-seeking and in how we can then move to that level of actualization that people were the realist review and the literature was sort of struggling with as well. So that's going to be part of our ongoing conversations with our patients. So this resistance and sort of try to make sense of the world and its complexity is a good thing, right? Being able to like create a narrative around oneself to like make sense of the world is all about supporting a patient-centered approach. Gerald Visenard speaks to this concept of survivance, which says that we as Indigenous people we're we're moving forward in this world in many positive ways, and these are the ways that we make sense of it, and we have to be resistant to it. We have to push against the system, and we have to be happy, and we have to connect, and we also have to say that's not right, and all that kind of stuff. But that becomes that we have to, as he said, we have to renounce kind of like some of those historical colonial stories of of uh, of uh, of marginalization and those things that oppress us. We have to push back against that. And so we were seeing those concepts and those ideas within the realist review process as the individuals were like telling their stories and pushing back and saying this is what it was, and I'm like, makes me angry, and this is what I'm going to do. And they were they were facilitating the creation of a narrative that allowed a space for them to make sense of it. And if it happens with you in the clinical interaction, that's great, and that could be part of what we do. But survivance is a concept that I think we all have to hold on to and foster, and say, yeah, it's good. I think people need a voice, and this is where people are at. It's part of that journey. All right, so here's another concept that that is, I think, underlying much of this work is the idea of the power of social connection, right? In the way that we see patients, in the way that we understand supporting people, knowing that society, Western society, the way that what we're trained can be very individual focused, and it's hard to separate the individual behavior from the structural issues that are out there. That's kind of like a paradigm shift for us. But it's a needed paradigm shift. Another aspect of that paradigm shift is this idea that there's social connections create better health outcomes, which is not like rocket science, right? It's like pretty straightforward. But how do we understand that and harness it and connect to it? And what is our role within health service provision, knowing that we tend to default to looking at just the individual and then judging that individual based on their behaviors, when there's a whole host of set of connections that are part of that healing journey, part of that strength, also part of the things that sort of, when it's disconnected, can make it harder on individuals. So understanding the extent of connectedness and connection and solidarity and good relationships is part of what we think is important to understanding when working with Indigenous people. And we saw this concept important within both the realist review group as well as was within the literature. So wanted to share with you that concept. Okay, so political and economic pathways. So this can be big and huge and hard, but if we sort of focus that, okay, so the political and economic pathways, these structural issues that impact Indigenous people, that sort of explains the first two pathways. How and also starts to give us some insight as to what is our role more broadly from a systems level, right? But it also makes us think about how do we potentially be complicit in this, right? Individually or at a system level, right? Because the healthcare system is one of those structures of society. How do we then, what's our role in addressing those things? So got to think to yourself, right? What are your notions and understandings and perceptions of Indigenous people in that moment? And if there's any dissonance with that, what do you do about it, and how do you make sense of it? How do you address those things? So if you look to the Truth and Reconciliation, there's a whole host of concepts of that education is transformative. So learning and understanding about this helps us to make sense of this. Having some structures to hold on to also makes sense to be able to like reshift and shape the way that we sort through things and understand if there's any interesting dynamic that we perpetuate within our interactions that we can make sense of. So there's a whole lot of thinking, and this aligns with kind of our current anti-racism sort of momentum within North America. How do we as health service providers actually see and not see the stereotypes, prejudices, biases, and discrimination that we are prone to do, because it's human, right? We have a tendency to like group as health service providers. We use categorical thinking. It helps us to see patterns within within the patient's life so that we get the job done. It's very human. We all do this because it allows us to function within a very complex world, and our world is getting more and more complex. So the idea here is that we could be complicit. right? So within the realist review group in the literature, we landed on this idea of that that colonization is a central concept that we have to understand, right? And we have a shared experience of it, and that we have to understand. So I know that I'm Indigenous, but I'm speaking as a service provider at the same time, as well as an Indigenous person. We have to understand as service providers who we are in the context of colonization, knowing that it's not just this thing that happened back then. It's kind of it's ongoing. It has its ongoing effects. We are complicit in it, and it operates in very complex ways, right? At a structural level, at a systems level, as well as at an individual level. And if you look to some of the work of around anti-racism, you'll start seeing a bit of a structure there by just looking at those basic terms. And the impacts of this is health access behavior, right? The avoidance of health care settings, the nature of the fear, the worry, the previous experiences of bad interactions can create this this hesitancy of Indigenous people to come to you. I often hear specialists in various domains of medicine say, I never really get to see many Indigenous people. And so that's a complex answer to that as to why. And one of the reasons why is that there's structural barriers for people to get to your clinic. So poverty, busy life, lots of issues in one's life that one needs to take care of at the family and community level often make us individuals deprioritize ourselves. But also if the system is unsafe for us, we like, oh, maybe I'm not going to go to that because I just can't cope. Parity speaks about, there's a threshold of racist encounters against yourselves, against Indigenous people that pushes people over the brink, over the limit of mental health, and that's after 11. and in my day-to-day life, interacting with Western society, you can get one a day, right? And if it takes just that, we exceed our threshold within a few days, right? So interfacing with Western society, we have to think about that as service providers, is how do we ensure the safety within that when much of the unsafe aspect happens along the way. So we have to be cognizant of that effect and do our best to understand it and work towards it. So these things are what the literature and Indigenous people are trying to sort out all the time and make sense of in that moment, right? Right. So this last quote, I think, draws into this narrative of a very interesting Indigenous person that was making sense of the huge complexity. So can you just take a read there and hold on to the ideas, and we'll move forward. Okay, let's go to the next slide. Within the concept of what we do, and in addition to the ideas of those how inequity drives obesity, we offer an additional lens, a facilitative lens. Knowing that each of those pathways operates at certain levels and offers really important and interesting opportunities for us to do an excellent job, right? And to harness our skills and our capacities and abilities to communicate effectively in a great way with Indigenous people. We offer this, the kind of notions around culture as a protective concept. Survivance speaks to the idea that there's something there that is inherent in community that is super profoundly strong, right? Whether it's like connection to culture as a set of knowledges, skills, experiences, it's coming to ceremony, whether it's the social interactions that happen, like social cohesion as a result of being engaged at a ceremonial, cultural, spiritual level. Those are all amazing things, and they happen. All of those things are happening all at the same time. The reconnecting of individuals to their identity, is all part of this, and all part of this healing journey that says, yeah, these are things that make sense. So when I spoke to that chief, his name is Leonard, and he talked about the story of political poverty. That's what we got to do, but at the same time, he facilitates ceremony, and he brought these, did a ceremony which was probably a smudge and a pipe ceremony and a sweat with these young Indigenous people that were that were suicidal, and he talked about complex cultural constructs that reaffirmed these ideas of continuity. He's speaking about the idea of identity, but more than that, I think Visinor and everybody else who speaks at this level talks about this idea of citizenship, the role that we have in moving forward as somebody important, and a role in society, continuity. And so that's part of the journey, right? And the respecting of that there is our Indigenous perspectives that kind of are, they're different. They're maybe fundamentally different than a Western perspective. Maybe they're not so different, but they're important, and they contextualize an understanding the world that makes sense, because that's kind of what they hear, what they see throughout their life. The resistance and the patterns that you might see could be from individuals that say, well, that doesn't make sense within my perspective. I'm trying to make sense of that perspective, but it kind of doesn't resonate with me. And so I want to push against this idea that you're putting on the table. So that's kind of that third point here, that be aware of we might have differences that between a Western and an Indigenous perspective in this moment. And that that one needs to be open to saying, what is it that you're thinking, right? What are the Indigenous perspectives that you feel you have some that we can work through? What's the differences? Like some of the cultural competency work that I did was working within my own clinic at the Elbow River Healing Lodge and getting perspectives of my own colleagues who are Indigenous. And an overwhelming perspective was that in the Indigenous people there, regarding the idea of cultural competence, which often the literature says, what are our similarities? And let's start from there. That's super great. There was a big theme of, what are our differences? Because I really want to know, like, I'm on, like this woman was speaking, I'm Anishinaabe and you're like Cree, and like, yeah, we can talk about our similarities, but I really want to know what our differences, because we can, like, it's really interesting. We can start making connections through that, and seeing what those are, because we can see a broader lay of the land and make our relationship that much more interesting and sophisticated and complicated. So let's talk about those differences as well in that moment, and let's keep a safe space for that, so that we respect each other, right? So that talks about our uniqueness, and then our autonomy she was referring to. So that's kind of the big concept here, is that there's a connection, that culture is very important and drives wellness, but we have to understand how to tap into this, right? There's a host of cultural concepts that we place within our recommendations, and I'll leave some of those concepts to those slides. So we think that that as health service providers, we should tap into that reality of the patient, but validate that person's reality, right? Knowing that the elements of stress have a certain conceptual concepts and theoretical backgrounds, and population health sort of evidence that shows those connections, whether it's Indigenous or not, non-Indigenous, that the experiences of poverty, whether it's just at the individual level or more broadly, are valid, right? And they drive one's capacity, and they operate at complex levels. And so if we validate that, we can start saying, what is it that we could do together to address the fundamental aspects that drive this, right? From a paternalistic clinical point of view, one can just blame the patient to move on. But if we see the opportunity to understand that there are these factors at play, and what is life like for you? Like, that's patient-centeredness. What is your life like? And so that makes me ask, okay, how do you actually ask these questions? What are safe ways to ask without making people feeling judged? So there's a host of literature out there that speaks to ways to start tapping into poverty. So just a slide to share some concepts of toxic stress that I've been speaking about. And you probably have seen this type of slide before. this was the underlying factor. We were chatting. I just want to go through some of the recommendations there. So this speaks to the operating at multiple levels recommendations. So working with the patient to recognize that these are feasible and they have entitlement to it. That I'm a helper and I want to help to address these things. And to get there, it takes a host of fundamental steps that maybe you and I can work together to identify and support, right? So basic stuff, it's good stuff. That resistance, apathy, and paralysis are things that we have to acknowledge in the moment and help each other and see within ourselves as service providers, but but work with patients and honoring and respecting that concept of resistance, or finding those points of apathy that really overwhelm them, because that likely is what people want to focus on or need to focus on in their life. So a bit of a helping hand as a helper, as a cultural concept, is a non-expert sort of model to help support people to be well. The first recommendation is systems-based. So this really points our fingers back on ourselves as healthcare providers. This is such a pervasive thing, and again, in line with current anti-racism movements across North America, we have to do a better job, and we have to start thinking about what it is that we see and then employ, right? And the projections that we might have on patient motivations and all that kind of stuff. And finding different explanatory models, right? So that's our next recommendation. In the complexity of resistance and survivance, and the idea that Indigenous people are quite wary of wanting to engage with something that could be toxic to them vis-a-vis the healthcare system, I have some expectation that this could be a worrisome place that could have been violent to them at some point in time, thinking about trauma informed, and how do you position yourself in a place to respect people as a helper. I brought this idea up. It's actually a specific power leveling sort of intention, where you as a helper at the foot of the person to help facilitate, versus an expert that stands above the person, which can be viewed as very abrasive and a point of resistance. So that's a concept to think about. I think we spoke about the other concepts a few times over the course of this. All right, so the idea here is that as health service providers have there's a health education, a knowledge translation, a knowledge exchange role that facilitates great outcomes, because knowledge is power, knowledge is healing. One's interconnection with that knowledge helps us to be able to have self-capacity. That is a longitudinal relationship that we saw as what the literature and the patients were asking for. It's not just like, okay, you're the doctor, you told me these 3 things, all these other things are happening in my life, I'm like worried about this interaction, I think you're racist, or I'm worried about that I'm really still annoyed with the clerk at the front, or the people in the waiting room, and I can't absorb that information, but you just told me 5-10 minutes of stuff that I can't keep track of in my head. And then you think it's over, that's not going to happen for me. So they're speaking about the need to have a longitudinal relationship that goes hand in hand with knowledge exchange, right? That explores these things over time. And these things can be quite brief as one goes through in a longitudinal fashion and learning together. Okay, in order to do the previous step, we all have to build our knowledge around this, right? To understand Indigenous health from a social justice and equities lens in order to make sense of this. So there are some resources out there. The diabetes stuff that we put on the table starts to hint at this and provide some clear stuff. We have we're building some more resources around this, but this is a lot of sort of professional development that we have to be responsible for and take agency on. So these are facilitative recommendations that sort of connect to the ideas here that if there's a patient-centered model that we need to hold at hand, we have to like elicit that interface of that person and have skills to be able to truly hear what's going on with that patient in their world at more than just their individual behaviors, but what is that contextualization within their world. So one of the Indigenous constructs that we saw within this evidence was the idea of reciprocity and interconnection, and that it's not just the individual, but it's the interface of the individual with their family and community and environment and broader constructs that drive them in good and hardship ways. So that's their job, is to expand our patient-centeredness to be beyond that specific individual. And so that last point there speaks to those notions of relationalism, and we hint at this idea of not sort of being too directive and say, you got to do this. This is like sharing stories around how do we like move forward in a way that's appropriate without being too instructive, which can be also off-putting. Okay, we're coming to the end here. So think about these sort of in summary, think about these things, consider these things when providing care. So I spoke at length about structures and structural violence and those inequities that drive health outcomes and are deeply intertwined with with obesity with Indigenous people. The next key message was the stress that operates within as a result of those inequities can make it hard for individuals to like be healthy, and it perpetuates health behaviors, right? And so we talked about some of those ideas as to what it might mean throughout whether it's self-care or one's interface with the healthcare system, right? And so seeing all these spaces that can be like typically like, oh, that patient's really difficult. I think I don't know what to do. I'm gonna, just it's really complicated. I don't want to open up the Pandora's box. That's a big can of worms. Let's just keep this simple. Our message is that those are opportunities, but for like great care and moving forward. So that social reality is important, as I've made sort of described many times. Thinking about and addressing our own assumptions is really important, and starting to think about one sort of at a cultural lens, like individualism versus collectivism. Those are concepts that could be at play very easily in that moment, just as stereotyping and stereotype threat could be at that play. Stereotype threat is the idea that a person might be expecting stereotyping in that moment, and all their energy is like scanning you as the health service provider to see if you're going to be stereotyping or biasing against them, and all of that energy is like focused on scanning versus hearing what's the message truly is. The last is validation of one's experiences can be empowering, but from a population health lens, social sciences lens shows how powerful that is, with some opportunities for shifting and influencing that healthcare behavior. So I think we've spoken about these things at the beginning. The complexity is big, and we have to have a structure to make sense of it. And it requires, and therefore our relationships with Indigenous people requires a long, ongoing weaving of this narrative that we can be alongside them in that journey to ensure that we can like make sense of it alongside with people. So it's the key word is providing care with Indigenous people. Right. These are the concepts that we're holding within communication and relationship with Indigenous people. That the connection and the relationship is also very therapeutic, and it takes much time to like start building and healing this relationship. One of the key ideas from some of the other work is that you have to recenter that relationship, knowing that colonization impacts it in many adverse ways. And there's a history of worry, a history of bad outcomes and bad experiences that you have to be aware of and not perpetuate and self-search to like create a better context, this ethical space for working with Indigenous people. I think I've spoken to these concepts throughout this presentation, and I'll leave it for our panel to chat more about this slide. All right. So in conclusion, like my introduction, it's complex, but how do you make it simple? Like, I'm a guy that does stuff and likes to do stuff. In conclusion, in working with Indigenous people, there's huge complexity. Understanding the central principles of colonization and how it works through stress, and how it works structural to systemic through our system and to the individual, leads to possibilities and opportunities for great care. That providing a personalized assessment to individuals is looking beyond the individual sort of motivations, behaviors, but what connects to those at all of those levels. It fits to an Indigenous idea of relationalism. It's in alignment with kind of best practices, and I'll just leave it there for our for conclusion, and open it up for the panel. I think is next.
Thank you so much, Lindsay. I really enjoyed your presentation, and I'm excited I'm going to have a recording because I want to listen to it again. We're joined today by Dr. Rita Henderson, one of the lead author on the chapter. Rita has a PhD in a background in social sciences and health inequities research. She's a models of care scientist in family medicine, and her research focuses primarily on Indigenous health, ranging from population health research to clinical intervention research to the integration of the two. So welcome, Rita. And we do have a question in the Q&A box to kick things off. And I just remind all of the attendees, please pop a few questions in. We have some time. So Jimena is highlighting that people with obesity experience stigmatization and discrimination in our society. And Indigenous people also face racism and marginalization. And these experiences interact and are major barriers to obesity care. So perhaps, Rita, you could reflect on some of those interactions, and both of you might be able to comment on how do we start to begin to unpack and overcome those barriers together with Indigenous communities, and how do we partner to change in clinical practice?
Hi, thank you. Yes, I think one of the things we heard very strongly in our realist kind of advisory group was that healthcare doesn't need to be organized in just a physician-centered way, and there was certainly interest. I think some of the people that participated even talked about how, like, coming together as a group and trying to make sense of all this was itself, had a therapeutic dimension, and that kind of like group activity and of a longitudinal nature, like not all necessarily wanted to do something of a group nature, but I think we could reimagine where exactly the physician is located in terms of the patient's experience of healthcare, and that while still central and important, things like peer mentorship groups that connect to both physicians and maybe other allied health providers, to allow for more engagement over a longer period of time to build that knowledge base is of value.
Mm-hmm. Absolutely. Yeah, so Lindsay, do you have some thoughts on Jimena's question?
I think Rita covered the key ideas. I'm feeling like I spoke so much today.
No, Lindsay was fantastic. Actually, just so that all the panelists and attendees know, we are planning another webinar series where we can unpack some of this a little bit more. I think we're going to do some more work on primary healthcare and the practicalities of the how. I'm always struck by what Michael Vallis and Dana Lee Bagley always say, for everybody, we need to not teach and tell. We have to collaborate and coach. And so how do we, that's a sort of shift in medicine generally, isn't it? I think a lot of the lessons from your realist review are so telling and important with everybody, most particularly with the group that was participating in your realist review, but it's really important that we do this with everybody.
Mm-hmm.
I think the idea of obesity and body image and stigmatization, that's really interestingly complex, like everything else within everything in the world. the idea of body image and what's acceptable versus what's not acceptable. If walking in one world, it's like robustness and all that stuff is fully acceptable because not just, maybe it's partially cultural, maybe it's also a history of starvation and epidemics. When we're told from a young age, if you're thin, I think you're sick, you better go to the doctor. um, the experimentation and starvation that we know that happened amongst Indigenous communities and residential schools, the history of policized policies for starvation and farming and all that kind of stuff, were clear. The point of extreme starvation that sort of was the moment of early colonization that then perpetuated life forward. Those are realities, and as if we have this idea that as a result of starvation and infectious disease we see wasting away, then we shift our cultural views as to what it is that is important. So I've had patients that would come to me and they're fit and they're like, very Western fit, very muscular, athletic. And they would say, my family thinks I'm ill, right? And I say, well, you're a volleyball player and you play hockey and like you're expending so many calories and you're muscular and everything looks great. I don't think you're unwell. I think you're actually pretty good, right? But my family thinks that I'm unwell because I'm thin, right? So there's a whole host of complexities within all of that, and stigmatism left and right, stigmatization left and right. So I think the conversation is complex, and I think it's really interesting and great that we could have those conversations. And if you get to that space with patients and with communities, those are healing spaces.
Right. And I guess, Lindsay, one of the things you said that just really hit me like a ton of bricks was when you were commenting on when people have experienced, 11 acts of racism, that can really be the tipping point, and that happens every day. And so what do you think is the most, so if someone is in clinical space with people and is trying to be therapeutic, what's the best way that they can try to start to unravel that ball of yarn?
Right. So think about an interaction as very dynamic. In an interaction, we often go into data collection mode, where we define the nature of the information that we want with a series of questions based on our clinical structure. And then we move into an internal sort of like, I'm formulating an idea based on that information, whether it's what the patient said, or physical exam, maybe some lab tests and all that kind of stuff. So we do this clinical formalization to analyze this. So we're kind of like always thinking about that at the same time. So we're busy in our heads, right? And then we get to the point of, okay, there's like I got to share the diagnosis, or I got to like sort of describe a management plan and negotiate. So then we move into like a giving information phase. And in all of that, there's a space that of reflectiveness that we probably don't tap into, a reflectiveness on the nature of the dynamic of the interaction. So what's happening in the nonverbals at that moment, that's where it starts, right? If you can like leave space in all of this busyness, which is really internal, to like see, you're taught in a physical exam in medical school, look at the patient's face as you're touching their tummy in case they're really in pain, right? And then all of a sudden, but your job is so complex and big, and you have a whole host of things, and you're like worried about this, you're worried about clinic flow, all of that stuff. Yet, are we looking at that patient's face, right? And reflecting on, is there a grimace there? And if there is something there, you stop, right? And say, hey, what's going on? Simple as that. So look for that dissonance, and tap into yourself. It's as simple as that. And then stop the moment. I know it seems like a lot of my work has been theater and stuff. And that's a fundamental process for us to recognize. We can say, hey, let's pause for a moment and chat about that. There's dissonance. trust that and then explore it and find out what it is. So that's a good space to start from in our, and we have agency in that moment.
Mm, wow. Well, thank you and Rita so very much for this. And we know that we aren't going to be able to get into all the many, many questions everyone has today. But, and I know people are probably a little bit shy because they don't even know maybe even how to formulate the question. I really love this chapter. I encourage everybody of the attendees, if you haven't had a look at it, please have a look at it. And remember, we do have our online Time Right community with Obesity Canada, where we can carry on with the conversation. Yeah, absolutely.
I was also going to add that we have a case in that chapter as well, and so if people really want to get more into the voice of the people that we worked with, looking at that case to try to think through and reflect on what could be done clinically might also be handy.
Yeah, and when the attendees, if you guys do the evaluation, which we would really appreciate, please put in there how you think you might value learning more about the space. And I'm already thinking about the next series that we're planning, and maybe Rita, Lindsay, it'd be awesome if we could do some cases and now that we've gone through some of the fundamentals and actually just dig right into some of these cases and how maybe people could navigate and try to be really helpful.
Yeah, I think it's a meaningful way to connect to the knowledge, for sure.
That sounds good. We're trying to build an Indigenous education hub in the medical schools that will help to facilitate that over time. But I'd be happy to help out because
That'd be wonderful. Yeah. So we'll regroup because I know for today people are probably zipping to clinic. So we're going to have to wind it up here. But thanks ever so much for all the work in the chapter, and thanks to all the attendees for coming to the series. And as I said, we'll send you an email about the surgery extra serve session, and then we're thinking about another series. So we'll make sure we advertise that out to everybody and getting into a lot more of the nitty-gritty of the cases. So thanks everybody for today, and thanks also to the team at Obesity Canada and the team at Lifelong Learning for all the behind the scenes work to put this together. Really appreciate Nicole and Melanie and Jessica and Dawn and Jimena and everybody who's made all of this possible. And so on behalf of Obesity Canada and the Office of Lifelong Learning, thank you to everyone. Have a wonderful day.
Thank you.
Thanks.
Yes, thank you so much, Lindsay. So I really encourage the attendees to just reflect. It's just an enormous amount of information, but if you have questions, please put some in the Q&A. For our Q&A today, we have joining Sean Morton and myself, Dr. Rita Henderson, who is the lead author on this chapter. And Dr. Rita Henderson has a PhD in background in social sciences and health inequities research. She's a models of care scientist in family medicine. Her research focuses primarily on Indigenous health, ranging from population health research to clinical intervention research and the integration of the two. So welcome, Rita.
Hello.
And it looks like people are shy right now, but I want to turn it over to you, Rita, just to reflect on your experiences, because this was such a rich process. And maybe you can share some of the insights and learnings you had with going through this process with the group.
Sure. I'd say that, early on in the process, we had to make a decision about whether or not there was even the ability to derive the types of insights we needed to from what was the current literature. A lot of the literature out there was very kind of population health focused, talking about really upstream drivers and not giving us much insight about what that means for clinical practice. And so we immediately felt that we needed to have a means of bringing that literature to people with lived experience to ask them what's going on here and how do you make this connection. And at first, when we put out a call within Calgary, it was a Calgary urban clinic that's Aboriginal Indigenous focused called the Elbow River Healing Lodge. When we first put out kind of like a notice of interest, I'd say we thought we'd be lucky if we could get 4 or 5 people of interest, interested in engaging. And we were doing it on relatively short notice. And we got 14. people, and they came from different places across Canada, including, you know, the far north, and really very different cultural backgrounds, and it just allowed these really rich conversations. And I'd say that, like, by the time we met over the course of about 4 weeks for 3 hours each time, and to talk through these topics and really get into some recommendations with them. And what was really interesting, I think, is by the end, they, you know, some of them were saying, like, well, you know, the type of model of healthcare that could work for us would be like groups like this, you know, being able to come together and make sense and like figure out what knowledge it is that we need and that we desire. And that was just really kind of like eye-opening at that time, to see how, because we were meeting within a clinical space within the Elbow River Healing Lodge ceremonial room when we met. So I'd say that was a very powerful insight and process.
Absolutely. It sounds really excellent. And it sort of turns the paradigm on its head of, you know, this model of care that's all around acute care, short interactions, brief, very transactional, into providing more space, right?
Mm-hmm. Yeah.
So Anne has a question, which is, you know, is there a suggestion you could make, Rita, about beginning to build a reputation of willingness to engage in an appropriate way with Indigenous people? And wondering, you know, if we don't have an Indigenous person on the staff, we may not see people in clinic. So what's your response to that thought, and how could Anne's clinic and Anne start to build some of those bridges and relationships?
Sure. So I am myself not Indigenous. I'm of settler background, and so I speak from that position. I can't speak for the comfort that some people may or may not have. But in my experience, I feel that the like I would just pose that is the presence of an Indigenous person the signal of safety for others, or is it them as an outreach for Indigenous people? Because I would say there's almost two functions at play. One could be having the presence of Indigenous inclusion as important, and so it could be just I mean, it sounds tokenistic, and it shouldn't, but ways of signaling to Indigenous people that it's a safe space. So the inclusion of art and maybe activities, or you know, practices that are, or things on the wall that indicate that you're connected to Indigenous community, like you know, numbers to connect to local friendship centers and other services that are Indigenous serving, that somebody could see and access, and, you know, see that you're signaling that in your clinic. The other is, you know, whether that person, that Indigenous staff person, is actually fulfilling a role of like reaching out to people. If part of their role is calling people up and following up and stuff like that, then that's also, that could be fulfilled by a non-Indigenous person potentially. And yet there's probably a certain knowledge and know-how of how to do that in a way that people will feel engaged, that is fulfilled by a person with deep knowledge of Indigenous context. So that's where I'd say there's like, you know, the passive signaling of inclusion, and more kind of direct and outreach oriented stuff that is of value.
Mm-hmm. Yeah, so Nicole has a question about the research and the grading of recommendations. And Sean's also posing a question about the difference of research. So Nicole's point is that a lot of the recommendations in this chapter are level 4 grade D, despite the fact that it actually did have a very rigorous process. So wondering if this signals that we don't value both qualitative and quantitative, or value Indigenous ways of knowing. So we did actually have a process for thinking about qualitative research in the guidelines, which was quite a departure from most other clinical practice guidelines. But I think Nicole's question is going a little bit further than that. So do you want to comment on that? Rita, do you feel that about how you guys did decide about levels of evidence, and sort of, do you feel that the way that we did this was perhaps not as open-minded as maybe it should have been?
Um, I actually feel that, and I don't necessarily hear that in the question. I think that the lead group on the clinical practice guidelines were very inclusive, and when we brought the idea of the realist review process and the fact that we had a reference group to the table, we actually brought it to the table after we had already done it. But partly because we had to make sense of how we were going to go get any kind of clinical guidelines otherwise. We had to talk to people. And when we brought it to the leads, this was very much received positively. I think I see the question as more directing at, biomedicine, Western biomedicine, and the healthcare systems in which we operate, and how the value of scholarship or evidence is assessed. And I think that that the grade levels, those are standards out there, yes, and I think researchers need to be nimble enough to recognize when the evaluation of the knowledge is limiting, and move accordingly. And I certainly learned that methods like the realist review process have allowed us to nevertheless demonstrate grounding in Indigenous knowledge. And I'm actually going on to use the realist review method in work with other disease entities, because I felt it was so powerful.
Mm-hmm. Yeah, it was a very powerful process. So I think, Nicole, the answer that Rita gave answered your question. It looks like I didn't understand it correctly, but it looks like we've covered that. And yeah, I think just that whole process that you've used with the realist review was really effective. Sean was asking if you could speak just a little bit about that process in terms of what's the differences from a normal realist review in terms of integrating some of those Indigenous components, and what did that look like?
Well, a normal realist review is very much focused on developing hypothesis theory that you test in the literature. So you generally come up with, you kind of define the context in which you're exploring the information, and you test a mechanism working in that, and then you define what the outcomes you would expect would be. We didn't write it up that way for the guidelines because we just wanted to be very concrete for practitioners, and we're still actually underway of doing kind of that more classical write-up of that testing of hypotheses. And we used we derived our hypotheses from prior work with the Educating for Equity initiative, and those 3 pathways approach, and the culture as protective that we lay out. And so yeah, we left a little bit, but it wasn't because of it being Indigenous specific. It was more about trying to apply a realist methodology to a clinical practice guideline, which I hadn't yet seen done elsewhere. So I don't know if we were among the first. Otherwise, I feel that there wasn't anything particularly different working in an Indigenous context, but I would say that I see a lot of potential for the methodology of realist review for Indigenous knowledge, because often what you get in a scoping review or a systematic review when it comes to Indigenous health research is more research is needed, the evidence base isn't robust enough to make conclusions of recommendations level. And here, what it allowed us to do is go, oh, hey, like what we're asking to see if it's in the literature is there. It exists in this way, and allowed us to describe what it looks like instead. And I guess the other thing that we brought to the table that might not be in a conventional realist review is the patient voices. And that was just a decision that we made at the point of publication, that it was important to have in text boxes patient experiences that aligned with each of the areas that we were analyzing, because it needs to be relatable and people need to recognize their patients in these perspectives. And we additionally added a case study for as a complement to the chapter, because we felt that again, we really wanted to drive home something practical, bring something practical for providers, instead of have the literature exist at more of an abstract level or population.
Awesome, Rita, thanks. So I think we should give our lead of the guidelines, Sean Wharton, the last word. So Sean, did you have some thoughts on this?
Yes, thank you, Rita. This was great answers, and Lindsay's presentation was terrific. I just wanted to let everyone know how proud we are of this chapter and a little bit about the process that went into it, and went into the fact that when we brought it to the CMAJ, you can imagine looking at level 4 grade D evidence and the fact that it had the most recommendations out of any chapter. We thought about making the recommendations shorter, trying to cut it down, and then we looked and read each one of them, and we loved each one of them so much that we couldn't decide on which ones could possibly come out. They were all so terrific. And we were excited about the fact that they were all level 4 grade D realists. And that put a stamp on the fact that the Indigenous research with the Indigenous people is different, and a tradition and the ways that we look at research doesn't always speak to it. So it was almost like we wanted it to be specifically this way, and CMAJ and many other people have embraced it as possibly the most exciting chapter that we have in the actual guidelines because of this. So I applaud what Rita and Lindsay did. It's just sensational.
Yeah, and I haven't seen it anywhere else, Rita. I know the Cochrane group is trying and talking about doing qualitative guidelines, but I haven't seen it elsewhere. So I'm just mindful of time. I think we'll give Carfu the last question of the series, and then we'll conclude. So Carfu is just reflecting from an Asian's Indigenous perspective. Obesity is viewed culturally as affluence. And the question just disappeared as I was looking at it.
Oh, sorry.
And there's a positive image in prestige, and they're proud of body size, which creates resistance about changing behavior. And we certainly see similar things in other cultures. So I'm thinking about some of the work we're doing with people from West Africa and different things. So she's wondering about suggestions about how to maybe deal with that. So perhaps Sean, do you have some thoughts for Carfu on how to deal with that? It looks like Rita put an answer in there as well.
Yes. Yeah, I know that there are challenges, and we think about that in Africa as well. I think as we start to emerge, the emerging world, as we know, is where the highest rising rate of obesity is, and the amount of medical complications are actually coming from that. So the change in the definition about obesity being adipose tissue that causes an impairment to health is very clear. So it has nothing to do with size and body perspective, body size and the weight. So it's the impairment of health. If type 2 diabetes is a problem, if osteoarthritis is a problem, if bladder incontinence is a major issue, or there's on and on and on, obstructive sleep apnea, fatty liver, then it is an issue. And that's where we have to actually look at it. So we try to dispense now those type of cultural connections. As a Black male, I know what happens with the Black populations, West Indian and both African populations, similar to the Asian populations. The bigger you are, the more wealthier you are, the more affluent, a number of other things, but this is changing. So I think we're just at the end of that kind of thought process, because diabetes is not fun. So I think that's where we'll be actually treating things now versus looking at just body size and the thought of affluence.
Mm-hmm. Wonderful. Well, we're a little over time, but I just want to thank all the attendees, and certainly Lindsay and Rita and Sean and all the colleagues who participated in the other webinars, and all of the staff behind the scenes. So the staff from the Office of Lifelong Learning, so Melanie, Jessica, Obesity Canada, and Nicole, who was very instrumental in the series, Dawn. It really took a lot of people to pull this together, and hopefully it's been of value to people. Please contribute your evaluations. We really want to hear from you, things we could do differently. We will be planning to do that bariatric surgery webinar, so we will email everyone about that and provide you with that opportunity. And we're certainly discussing further programming as well, because there's been just such tremendous interest. So once again, thank you so much, everyone, and have a wonderful evening.
Thank you as well.